Well, hello everyone. I'm Karthik Murugiah. I'm an interventional cardiologist at Yale University in New Haven, Connecticut, USA. I'm also the executive associate editor for JACC. And I'm really excited. We're being joined together by Dr. Helle Søholm and Dr. Martin Frydland, both from the Copenhagen University Hospital, who are going to talk to us about their two trials, the Doberman set of trials. So welcome, Helle, and welcome, Martin. Could you just tell us a little bit about yourself, your group, and then we can get into the study?
Thank you so much, and for the kind invitation for this interview. My name is, as you said, Helle Søholm, and I'm an interventional cardiologist working in PCI and structural heart disease.
Yeah, my name is also, thank you for my perspective for this kind of invitation. My name is Martin Frydland. I'm a heart failure doctor, had been conducting studies in ischemic heart disease and STEMI patients at risk of cardiogenic shock development.
Awesome. Okay, so these are two trials, and we are obviously publishing them as two kind of parallel brief reports, and it worked out well for us because there's obviously there's shared features between these two trials, and the entire methodology is already online, which we reference in kind of the methods paper that has already been published. So it worked out well for us to kind of position these two together like this. So can you tell me a little bit about your motivation for this study? What is the specific population we are looking at, and why is it important?
Yes, and thank you so much for accepting our papers. And we agree that it's been very good to work with you, and we have reached two very interesting papers in our perspectives, at least. So the motivation for the study is that in STEMI patients, the outcome has increased and has been better in recent years, whereas in patients developing cardiogenic shock, the outcome is with a mortality rate of about 50%. That is quite high. So we thought that a lot of patients with SCAI-A or maybe SCAI-B are not very looked into in the research in the past. So we wanted, with this study, we had two aims. Actually, we had more, but we had two aims. And first, we wanted to see if we could identify these at-risk patients before they progress to cardiogenic shock and leading to a poor outcome. And two, we wanted to examine in this 2x2 factorial design whether we could stabilize the hemodynamics by providing the patients with dobutamine or in a placebo-controlled manner. We wanted to test if we could slow down the inflammatory processes with Tocilizumab, which is an IL-6 inhibitor.
That's great. And obviously, these population is very important because a large proportion of them are converting to cardiogenic shock. So, this is sort of an extremely kind of new and domain and trying to obviate this kind of decompensation down the road. So, we all thought that, there was a great area to work on. And obviously, hemodynamic agents, we obviously have to use them when there's shock is developed because that's what kind of we use. But they've carried risk signals in other populations like advanced heart failure, etc. So, this is a great test, so to speak, of the safety of these agents in this kind of shock continuum. So, I thought that was awesome as well. And obviously the anti-inflammatory agents, they are really, a really important topic of focus by various groups around the world at this time. And you guys here are focusing on an IL-6 agent in this trial, which is a single dose. Is that correct?
Yeah, that's right.
Mm-hmm. Yeah, and maybe Martin can answer this one. Can you tell us the process of how these patients were screened into this trial? We obviously used a particular risk score here, which is the ORBI risk score,
Yes.
which you guys chose. How was the recruitment done? Did you have coordinators there? Was this through EHR? Tell us a little bit about that and the specific interventions and the timing of them.
Well, we have two very talented young colleagues, one of them who developed the system for EHR identifications of the patient. So when the patients arrived at the hospital, the nurses, the staff in the cath lab started identifying patients, putting in the data and the variables in the ORBI risk score. So, and when the patients had an ORBI risk score above a certain point, our 2 young PhD students were alarmed at home, so they could go to the hospital and trying to include and recruit the patients for the study in a timely fashion, fashionable manner. So this has not been done in this way before in our hospital, but I think it has great potential for future studies. Also, more or less eliminating the human factor regarding calling the study personnel and getting them later on, so they were alarmed already at an early stage. And I think we've done everything we could to ensure that we could include these kind of rare patients in this setup.
Got it. And so these patients then undergo PCI, is that correct? And then
Yes.
they are exposed to this intervention.
Yes.
Okay.
Because
and
of
what is the
because of the post-PCI TIMI flow was a part of the ORBI risk score, they had to have PCI. This was an inclusion criteria for us as well. And then after ended PCI, they were given up to 2 hours after post-PCI before being able to be included in the trial. So they had also time to give consideration regarding informed consent.
Awesome. And what were the dosages used of the dobutamine infusion? Was there could that be titrated? And whether, and the tocilizumab dosage and timing? Could you just tell us about that?
Yeah, we chose a fairly low dose of dobutamine, 5 micrograms per kilograms per minute. And this was based on, especially seen in previous trials, such as the previous trials that we saw that there was an issue regarding arrhythmias in high dose inodilation. So we chose a fairly low dose in these patients, especially since there were no clinical indication for the hemodynamic intervention. Obviously, if they had arrhythmia or an increased heart rate, unacceptable high heart rate, we could decrease the dosage to 2.5.
Got it.
So, and for the tocilizumab, we chose a fixed dose of 280 milligrams as a single infusion, which was the same as in the previous ASILE trial where they gave it pre-PCI, but somewhat lower than we previously given in our institution in the IMICA trial, which was substantially higher. But we tried to use the same dosage as previously used in
a single fixed dose. Got it.
Yeah, exactly.
And obviously, SALMI was conducted in all comers of STEMI and not a high-risk population like yours, at risk rather for cardiogenic shock, which distinguishes itself. And you mentioned the IMICA trial, which was more in cardiac arrest patients. So this is a unique population that we have looked at in this trial. That's great. Now, what are the outcomes of the trial for the 2 separate portions of the trial?
So we chose, for this study, we chose a surrogate marker of a hemodynamic compromise. We chose the NT-proBNP, and we did that to, as this study was a phase 2, a feasibility trial. We didn't want to include a lot of patients if we didn't see a signal in this trial. So that's why we did it like this and didn't choose like a clinical outcome or a combined clinical outcome, because if we had chosen that one, we should have included much more patients, and that could have taken a lot of time. But we can maybe talk into whether we should do that for the next trial. I don't know. But the primary outcome of this trial was NT-proBNP, the peak of that hemodynamic surrogate marker. And we didn't see a significant difference in the dobutamine or in the tocilizumab groups as compared to placebo.
And multiple samples are drawn of this NT-proBNP through the hospital course. 12 hours, 36 hours, 48 hours. So any of them is kind of the peak one. So, obviously we'll talk a little bit more about it. An interesting choice and outcome, but obviously it's supported by, it's not been used like this before, but there is good hypothesis behind it that, a reduction in NT-proBNP could be, a good thing and show less hemodynamic decompensation or worse outcomes, that there is an association with that. So that is why, is that right?
Exactly.
Right.
Yeah,
So
correct.
that's how you guys chose that.
Yeah.
That's great. Any other outcomes in addition to the NT-proBNP?
Yeah, I can just add that we had, as you correctly mentioned, we had a sample drawn at during the PCI or after the insertion of the introducer, the sheath, and then we had 5 more collections of blood tests, and the primary outcome was corrected by the baseline NT-proBNP, because we did see they were not quite balanced, the 2 groups, with regards to the baseline value, but we corrected for that in the primary analysis. So we had the baseline NT-proBNP, and then we took the peak of the NT-proBNP as a primary outcome. With regards to secondary outcomes, we had the temporal change of the NT-proBNP. So that is the curve from seen in the central illustration. And in the Tocilizumab group, we did see a significant reduction after 12 hours of a reduction of 22%, reaching statistical significance. And after that, we saw a numerical difference between the 2 groups, but it didn't reach statistical significance. Whereas in the Dobutamine group, no differences were noted throughout the measurements. So that is the most, to us at least, important secondary outcome. But we also included we did a CMR, a cardiac magnetic resonance imaging, and we looked into the left ventricular infarct size. And interestingly, and opposed to the results of the ASILE trial, we didn't see any difference in left ventricular infarct size. And that was taken at 48 hours and after 3 months, and no difference were noted between the groups in either of the arms of the trial. Nor we did not see any difference in the infarct size. So the infarct size normally gets smaller after 3 months, but we didn't see any change at all. It was just the same.
You're comparing it to the ASAIL-MI trial, in which they did notice an improvement in salvage. But there are some distinctions in the timing of the
study drug,
study
because
drug
in the
here.
ASILE trial, they did administer the Tocilizumab prior to the primary PCI.
I see.
And as you already mentioned, it was an all-comer trial, so they included all STEMI patients, whereas we included at-risk patients. And in that, you can also see that the infarct size in this trial was very large. It was above 20%. Correct. And in the ASILE group, it was around 8, if I remember correctly.
Yes. Okay.
So they had large infarcts in this DOBERMANN trial.
Okay. So, just to summarize for our viewers again, NT-proBNP, we noticed no differences in both kind of the trial arms, but in the Tocilizumab at 12 hours, we did notice kind of some difference. So potentially there are some, good signals over there. And specifically now talking about the Dobutamine part, I think the 2 concerns we obviously were also testing were adverse events and what it does to the hemodynamics. And what did we learn from that aspect?
We saw no safety issues. I guess despite it hadn't been tested probably in a contemporary cohort, I guess we feared that there might be a safety signal both regarding infarct size but also arrhythmia, but no signal seen at all. I guess we saw what we expected, somewhat lower blood pressure during the infusion, somewhat higher heart rate during the infusion. So this was as expected, fortunately, you might say. So the hemodynamic effect of the inodilation was as expected with no safety signal. And of notice, this was given in CCU and not in Denmark. We have the CCU and the ICU. So we gave it in the CCU, and this was safe to administer in a PVK, and it wasn't administered in a CVK. So this was nice to see as well. This was feasible in this type of population.
Okay.
And maybe I can just add that we examined a combined safety endpoint, looking at death and arrhythmia in the Dobutamine group, and we didn't see any difference in arrhythmias requiring intervention. And in the Tocilizumab group, importantly, we didn't see any difference in serious adverse events nor in serious infections. That could be a concern with these two drugs, but no difference at all was seen. And that was regards to during admission and also after 3 months. So no late serious infections nor anything else was noted.
Yeah, that's good to know. Yeah, and obviously, you know, like the lack of an adverse safety signal is helpful for designing future trials using hemodynamic agents. So I think that's a great insight from this. One thing I want to highlight, and you guys can speak for as well, is about a large number of patients had to be screened for you to obtain these 100 patients. And can you tell us what you learned from that, and you know, and tell us a little bit how what you learned about how shock behaves in these early hours? It seems like a lot of patients declare themselves and things are very active. So can you tell us a little bit about that? Maybe Martin.
So we used the ORBI risk score, which seems like state-of-the-art risk score for identifying STEMI patient developing in-hospital cardiogenic shock. And we have previously looked at the predictive value of the ORBI risk score in a Danish 10-year-old STEMI population, and it performed quite well. But I guess what we experienced in this study was that patients at risk of developing in-hospital cardiogenic shock most often did it in the cath lab, which was not a surprise, but from a study perspective, it was a challenge since we weren't able to include these patients because they deteriorated early on during the hospitalization.
Yeah, I can just add that I agree with what you said, Martin, because the ORBI risk score is developed retrospectively, and we used it prospectively, and we did find a few defaults, as you have highlighted, that you need to perform the PCI, you need the TIMI flow after the PCI, and you need the culprit lesion prior to being able to have the ORBI risk score. And when looking into this, we see that more than half of patients developing cardiogenic shock do so in the cath lab prior to inclusion. And when we got the ethical we got the ethical permissions for this study, we had to take informed consent. We couldn't use the deferred consent for this trial. So one take-home, I know we're not at take-home messages, but that looking into further studies in this area is that we highly recommend that you should have ethical allowances to do deferred consent. And that is that you include the patients and you ask them afterwards. Because these patients, they have, it's very difficult for them to take in information after a large acute MI, a primary PCI, maybe it's in the middle of the night. They have to take in a lot of information. Do you want to be in this study? Do you want cardiac magnetic resonance imaging performed? And so on. So if you can include the patient, give the trial, insert the drug infusion earlier, I think it would be beneficial, because it's not difficult to find the patients, it's just difficult to include the patients, if you know what I mean, the difference between those two.
Yeah, we had a concern regarding selection bias towards the better patients in this population, because they had to be well perfused and quite aware to accept to participate in the study. So I fully agree with Helle that this would be something to take into account in the future for sure.
Yeah. And obviously, you know, this risk score was supposed to identify much higher proportion of patients who would subsequently develop shock, but that did not occur in our population, in your trial population, obviously, because many of them quickly are developing shock in those, you know, just an hour before, during, or after PCI immediately, which, you know, is really important for the future design of trials, because those are also the patients that we are hoping or aiming to intervene on. So maybe upfront interventions, or maybe even quick dynamic ways of assessing shock and pre-shock severity. Although you guys already took it to a much higher level, working with the EHR, with automated alerts, I think that's a vast step forward already. But maybe we need to push the envelope more in that of kind of dynamic risk assessment, and maybe potential risk scores in the future that could help enable that.
Yeah, I agree.
Yeah, that's great. I think, we're sort of, at time as well for this video, and I think we've kind of, focused on some of the issues that we had hoped to. So again, I'll thank you, Helle and Martin, so much for, considering us for your research work, and also joining us today for this video interview. And I hope it's useful for the viewers to give some perspective on the trial.
Thank you so much.
Thank you.
Yeah.
Thank you.
Thanks.